This is a patient referred after femtosecond laser cataract surgery done 4 years earlier. His silicone lens is significantly pitted after YAG capsulotomy treatment. He has a large YAG opening. He also has a femtosecond laser arcuate incision that has undergone a sterile melt and is causing significant astigmatism, which you can see here on topography. His refraction shows significant hyperopic against the rule astigmatism. And Barrett formula tells us he would benefit from a toric lens with 3 diopters of power. Here we're in the OR and we're going to place pars plana trocars at the beginning of the case. These are placed 3.5 millimeters posted to the limbus. We'll now go ahead and make our paracentesis. The goal is going to be to try to get this lens out and place a toric lens. The haptics are in the capsular bag, but the anterior capsule rim is fused to the posterior capsule, and it's very hard to separate the anterior from the posterior capsule because of this fusion. So here we're going to try to enter with LASIK cannula right where the haptic is entering into the capsular remnant, and try to see if we can get this opened up. But I'm having a very difficult time trying to enter the space between the anterior and posterior capsule because of the fibrosis. So here we're going to use a 30 gauge needle and try to slide under the anterior capsule rim and see if we can delineate this plane and pick this open. Here you can see this is where the anterior and posterior capsule are fused. And I'm trying to separate this a little bit using the 30 gauge needle, but I want to be careful not to damage the posterior capsule as I do this. I'm now going to try to enter with a viscoelastic cannula, and as I push down on the haptic, I can enter in and get some viscoelastic into that space and start to separate the anterior and posterior capsule here. Here I can see the anterior capsule starting to separate as I work my way around. There's a lot of Soemmering's ring lens material in here that's being kicked up as I inject, and we'll deal with that later. So now I'm using the viscoelastic to separate the anterior and posterior capsule 360 degrees so I can free up this lens and remove it. Now I'm going to make my clear cornea incision with the 2.75 millimeter keratome so I can take out the lens. This is a micro grasper, and I'm able to now pull this haptic out of the equator of the capsular bag remnant. We can now remove the other haptic in the same fashion, just pulling this out of the capsular bag remnant and bring this up into the anterior chamber. We're going to go ahead and cut this silicone lens in half. And this lens, it's very soft, cuts very easily. And we'll pull each lens half out. Now we're going to try to inflate the capsular bag remnant, the donut of capsular bag, to create a place where we can put the single piece acrylic lens in the capsular bag remnant, under the anterior capsule and over the posterior capsule. We inject this and tuck it under the anterior capsule rim as we inject, and then grab the trailing haptic and try to position this under the anterior capsule and over the posterior capsule. We're now going to dial the lens into the proper position, rotating it with a Sinskey hook. I'm being careful not to push too hard as I do this, just to sort of gently rotate this. And I'll leave it just shy of where we want the lens to actually end up. As I do this, it's kicking up a lot of Soemmering's ring material, which we're going to deal with in just a moment. So now we'll go through the pars plana and start doing a vitrectomy and removing some of this liberated material. This patient was also bothered by significant vitreous floaters. He had cloudy turbid vitreous, and we're going to clean that up as we remove some of the Soemmering's ring material that's kicked back into the vitreous as well. So here we're doing pars plana anterior vitrectomy. We'll now move the infusion line into the anterior chamber so that we can do a cleanup in the anterior chamber. If I use posterior infusion, the chamber was shallow, so I'm switching to anterior infusion so I can shut the cutter off and use the vitrector on aspiration only to remove this cortical Soemmering's ring material from the capsular bag fornix. As I do this, I'm ascertaining that the lens is indeed under the anterior capsule and over the posterior capsule in the capsular bag equator. So I'm removing all of this Soemmering's ring lens material. And now we're going to go ahead and complete the pars plana vitrectomy using posterior visualization to remove all of the vitreous floaters and any of the lens material that's fallen posteriorly during the manipulations. And here you can see that the vitreous is quite turbid and cloudy, and this is something that was bothering him. He was aware of this. So here we're going to clean all this up. And this posterior vitrectomy is edited quite a bit just to sort of highlight removing the vitreous and any of the lens material that's fallen posteriorly. And you can see how nicely this clears up. The vitrectomy is completed, and now we can see how much clearer the view of the fundus is. Now looking with the red reflex view, you can see the anterior capsule rim at 6 o'clock, and this demonstrates that the lens is indeed on the proper axis and in the capsular bag equator. The trocars are removed and the case is completed. Day 1 post-op, the patient saw 20/20 uncorrected. Here's a view from the slit lamp. The eye is very quiet, the lens is clear and in good position, and his autorefraction is very close to plano. Thank you for your attention.